morning, doctors, and welcome back to a new guideline video. Today we gonna read through the cystic fibrosis guideline. Guideline is so quick, and I will go through them so quick because it's too long. We need to focus on the important points that we need in practice, and we need it for the exam. Okay, the first thing that cystic fibrosis admission, when you are going to admit a newly diagnosed cystic fibrosis case. Okay, let's start. So arranging for admission, for elective admission, refer to admission plan in notice or clinic letter. So if this patient was referred for you from his GP, you have to revise that referral letter from the GP or from a clinic, whatever. If he has any previous notes or admission plan written from the GP himself, you have to revise that for admission. For acute admission, discuss with cystic fibrosis team. If he was acute, he is not referred from anywhere. He just came into the hospital emergency room and he discovered that he is cystic fibrosis, or since he was born, he discovered his cystic fibrosis, and you are planning for acute admission. So you have to take advice from the cystic fibrosis team. Always admit to a cubicle. Okay, so this is very important for infection control. Admission procedures: plot baseline weight, height. Of course, we will start with the weight and height and measures to plot it in the growth chart. Perform flow volume loop spirometry on admission day if aged 6 years or more, because children less than this age cannot do the spirometry. They cannot blow onto the spirometry machine. So weight, height, and the spirometry. Review his medication if he is already on medication. If he is a migrant coming from another country, for example, not diagnosed before, he is already diagnosed, he is going on medications, he has already plan written. You have to revise all this stuff. Okay. Okay, so review medications with patient, parent care, and last clinic letter. Prescribe all medication. Check whether annual blood could conveniently be taken now. Okay, ask nursing staff to inform the physiotherapist and dietitian on a day of admission. So you have to involve the PT, physiotherapist, and the dietitian. Check specific aspects of management or investigations as described by CF team. It's very important. For IV antibiotic, we will check the exacerbation guideline later, and we have the bowel obstruction guideline as well, which is the intestinal obstruction syndrome DIOS guideline. We will read those as well. Investigations. So the initial investigations for a cystic fibrosis case: bloods. If child admitted for IV antibiotic, send bloods when the cannula or long line is inserted or portacath accessed. Okay, send full blood count, urine electrolyte, CRP, LFT, and blood cultures. So this is your baseline investigation. If allergic bronchopulmonary aspergillosis suspected, request total IgE, specific IgE to aspergillus, and aspergillus precipitans. Okay, so that's what I'm going to do. So if I'm planning to insert portacath in place, so that's the patient will not need to be punctured every time he comes to the clinic. So portacath in situ, because he will take antibiotic for a while. So once you insert that, or you insert cannula, you will take your basic blood test, which is full blood count, your electrolyte, CRP, LFT, blood culture. If you are in doubt whether he has bronchopulmonary aspergillosis or not, you have to ask for total IgE, specific IgE for aspergillus, for aspergillosis. Okay. So microbiology on admission, request sputum cuff swab for microscopy and sensitivity. So the sputum sample is very crucial in here. You have to request it, whether sputum or cuff swab. If clinically indicated, consider sending nose and throat viral swab. You think to also of throat swab or nasal swab as well. If non-tuberculous mycobacterium infection suspected, send sputum for NTM culture, which is non-tuberculous mycobacterium. Repeat sputum cuff swab for microscopy and sensitivity 1 to 2 per week during admission. So while he is admitted on the ward, you will send the sputum or cuff swab at least once or twice a week, usually performed by physiotherapist, because he will help him to expectorate the mucus out of his chest by exercising. So the physiotherapist will help out with this, but check this has been done. Okay. If a new pathogen found, we will, okay, this is already the, written in the microbiology guideline. We will read it later as well. According to the pathogen, we will start the antibiotic, the specific antibiotic for the child. So for microbiology, we I want to summarize again, sputum or cuff swab for microscopy and sensitivity, nose and throat swab as well. You send a sputum for non-tuberculous mycobacteria as well culture. We repeat the sputum and the cuff swabs once or twice a week during the admission. You can ask the help from the physiotherapist for the to obtain the sputum or cuff sputum sample as well. What's about the imaging? Chest X-ray, if a new clinical signs present when examining chest, order chest X-ray. While you are doing the clinical examination as well for the chest examination that we know all, if you find any chest finding, crepitation, decreased air entry, dullness, whatever, you can request chest X-ray at that time. Most children have chest X-ray every 12 months. Check when last one was performed. If in doubt, discuss with the CF consultant. Okay, so basically, most of the CF children, they will have chest X-ray every 12 months, which is what that means. It's chest X-ray in annually. So it's not routinely done every single visit to the cystic fibrosis clinic. So bear that in mind, okay? If you are in doubt and you are not sure in that visit, you need to do chest X-ray. So you have to discuss that with the CF consultant first. If a new chest X-ray performed, always compare with the previous. So if you have got a new chest X-ray in this visit, you have to compare it with the previous chest X-ray of the last visit before. If recent CT performed, review finding and discuss with CF consultant and radiologist. You have to involve the radiologist in this as well, because he is the only person, he can read for you the CT scan perfectly and in a true and in a right way. So you involve in this your CF consultant and the radiologist if you need to do CT scan. Okay, lung function and oxygen saturation. Okay, perform spirometry on admission. That's very important. This is your basic spirometry. Then weekly on all children who blow reliably, usually aged 6 years or more, undertaken by physiotherapist or trained nurse. If evidence of airway obstruction, repeat spirometry 15 minutes after inhalation of salbutamol, metered dose inhaler, 4 puffs via a spacer. Okay, that's perfect and so clear. So once you have decided that you are going to admit this child, so you will do the basic or the initial spirometry, which is lung function test, done in the first visit on the day of admission. So you involve the physiotherapist in this and a well-trained nurse. It's not the doctor, it's not you who is doing this spirometry for the child. It's a trained nurse or a physiotherapist trained very well, okay? Initially, they will do it without any inhalers. This child will not take any bronchodilators beforehand. So he will do it. If there's any signs of airway obstruction in his reading, you will repeat it 15 minutes later after he taking the salbutamol MDI 4 puffs via a spacer. Monitor oxygen saturation overnight for first 2 nights after admission. So the first 2 nights in the hospital after admission, you will measure the oxygen saturation overnight for the first 2 nights. It's very important to know that. If saturation is less than 91%, prescribe oxygen via nasal cannula or face mask. It's very, very important. Okay. Screening for hyperglycemia. All right. Approximately 8% of children with CF develop diabetes after aged 10 years. Usually manifest as weight loss. Ketoacidosis is very rare in this situation. Okay. So let's say we have a child diagnosed with CF since he was born and he is now 10 years old. So it is a time now to screen him for hyperglycemia, which is diabetes really, which is CF-related diabetes, CF-related diabetes. So it's very important to remember that at 10 years of age and over, you have to screen him now. You have to screen him now. Do not wait. Okay, he may present it with a chest exacerbation, weight loss. It's unexplained symptoms. If taking regular oral corticosteroids, screen for glucose intolerance at admission. If he's already taking steroids, that's crucial to bear in mind that the side effect of steroids, they will bring the glucose up. So you have to screen to do for him glucose intolerance test on admission. During first 24 hours after admission, request finger prick blood glucose before breakfast and 1 to 2 hours after every meal, and at 2 hours if on overnight feed. Okay, that's very important if he was 10 years old. Okay, if he was 10 years old, you will do that for CF-related diabetes, or if he's already on corticosteroids. All right. If prednisolone started on dosage increased during admission, repeat finger prick blood glucose. Okay, if blood glucose elevated, discuss with the CF team. If you have found that his blood glucose is going crazy, you have to discuss that with the CF team. You involve the CF team in every single step you are doing in here, and don't forget that. Annual bloods. All children attending CF clinic have annual blood screening. Perform annual blood if admission within a month of annual screening, usually at time of birthday, during insertion of long line or portacath needle, or when checking to bramycin level. Okay, so the annual blood screening for CF patients is done once a year. So that's usually around his birthday or her birthday. And when you are going to change the portacath, for example, you have to take these annual bloods on that visit. Okay, the second page. Okay, what are the annual bloods that you are going to take? We have for the all ages, whatever was the age of that patient, you will take the FBC and blood film. So for blood count and blood film, vitamins A, D, and E, parathyroid hormone, uroelectrolyte, CRB, LFT, chloride, bone profile, magnesium, Pseudomonas aeruginosa antibodies, glucose, total IgE, specific IgE to Aspergillus, and Aspergillus precipitans. Okay, so these are the basic annual bloods you will ask for the all ages for cystic fibrosis patients. So again, full blood count and blood film, vitamins A, D, and E, parathyroid hormone, uroelectrolytes, CRB, LFT, chloride, bone profile, magnesium, Pseudomonas aeruginosa antibodies, glucose, total IgE, specific IgE to Aspergillus. If aged 10 years or more, you will add on top the glucose tolerance test at 0, 60, and 120 minutes. So that's pre-prandial and post-prandial. Okay, the nutrition is very important part in here. Always involve the dietitian. Wait twice weekly in nightwear and before breakfast. Weigh babies naked if possible. Continue normal supplement. So it's very important to involve in here the dietitian, and you need to weigh the patient twice weekly, 2 times a week. Pancreatic enzyme supplement, continue same type and dose of pancreatic supplement as already prescribed. Starting dosage for a newly diagnosed child. So the pancreatic enzymes, it depends according to the age in pediatric. So in infants, there's the Creon micro for children, half scoop to 1 scoop per 120 ml milk or breastfeed. So that's so easier for the moms to understand the dose and how they can measure it. It's half a scoop or 1 scoop per 120 ml or breastfeed if he is breastfed, or Creon 10,000. So the previous one is 2,000. It's 2,500 unit lipase. 2,500 unit lipase. It's half a scoop or 1 scoop of 5,000 unit lipase. So, or the other type, it's 10,000. So quarter. So that's yes. So that's quarter to half per 120 ml milk or breastfed. So you have to have a chat with the mom and teach her how she can give her baby the proper dose. Okay, and according to the saturation. Okay, for children, starting dose Creon 10,000, 2 capsules per meal, 1 capsule per snack. So that's 2 capsules per meal and or 1 capsule per snack. Dose titrated with fat content of meals and snacks to control symptoms of malabsorption. Maximum 10,000 unit lipase per kg per day. Higher dose can result in colonic stricture. So that's very important, that side effects of the side effect of Creon or the pancreatic enzymes capsule, when they take a higher dose, they may predispose to colonic stricture. It's kind of when the colon from inside interior, they will get structures stick to each other and may end up with intestinal obstruction. Okay, signs of malabsorption. Fatty pale stool, frequent smelly orange oil, excess flatulence, abdominal pain. Discuss with cystic fibrosis team as well in this situation. Proton pump inhibitors, if taking large dose of pancreatic enzymes, more than 10,000 unit lipase, discuss with CF team need for concurrent proton pump inhibitors to reduce the activation of pancreatine. Okay, so so that's another important point in here, that if the child take a large dose of pancreatic enzyme, you have to, which is more than 10,000 unit lipase, you have to discuss with the cystic fibrosis team if he can take, or if he need to take, the proton pump inhibitor to reduce the activation of pancreatine. Okay, that's very important. Okay, vitamin A and D and E. Starting dosage for newly diagnosed patients. In infants, you start with 0.6 ml Dalivit and 0.5 ml alpha tocopherol acetate, which is vitamin A. So you'll start with 0.6 and 0.5 ml vitamin E. Children, 1 ml Dalivel or 3 ppc multivitamin capsules and 100 milligram alpha, which is vitamin E as well. So anyway, don't worry about the doses in here. In your practice, in your workplace, you will check the BNF all the time. You are not asked to memorize all these doses. So you will check your BNF on the go. Vitamins levels are checked annually, and dosage adjusted accordingly. So as we have mentioned before, in annual blood check, we ask for the vitamins A, D, and E. Also, oral sodium chloride only if prescribed by CF, often needed in first year of life after diagnosis has been made. So the oral sodium chloride, they prescribe the oral sodium chloride, but only with cystic fibrosis team if needed, and usually if needed, they prescribe it in the first year of life after the diagnosis being made, and it's not your job, it's the CF team job. So that's the admission guideline for cystic fibrosis, guys. I will send another videos about the exacerbation microbiology and distal intestinal obstruction syndrome for cystic fibrosis, and we can cover all the CF guideline. Thank you for watching. I wish you enjoyed this one, and wait for more videos. Thank you.